our numbers are just going to climb for the next little bit. But for all of you that are here right on time, welcome, welcome, welcome. I'll say it in person. We are so glad that you're here. Thank you so much for supporting these trainings. It's been an amazing experience for us as we move month to month with, this group just growing so much. I want to start off with, excuse me, just with, like I said, a few announcements. Today, for our code word, as you all know, we have a code word for the training. And that word is process, because we're going to be talking about processing today. I thought that would be a good word. So write that down. Process, if you lose connection and you want to be readmitted, then you're going to want to email that word to Gabby. Make sure you let her know if your name is not at the bottom of your picture, she's not going to know who you are. If it's like says iPhone or some number or whatever, please let her know so she can identify you when you're trying to get back in. I will put that in the chat as soon as I'm done with the announcements. I'll put her email and that word in the chat so that you can go back and find it, but it might be easier just to write it down for quick access. Also remember that if you're looking for CEUs, that evaluation link will be put in the chat at the end of the training. Gabby's great about starting that about 15 minutes before the end, and she just puts it in several times. So watch your chat. We have still several people that will email us and say, I couldn't find it. Watch the chat and you'll see that evaluation link, and you can just click on it and fill it out. Now we're going to have a big group today because it's ethics and we always have much higher numbers. So there's a chance that if you try to click on it right then, you may not be able to get in because everybody's doing it at the same time. If that's the case, just copy and paste it somewhere and you can just do it a little bit later. Just keep trying. Sometimes you have to go off-site to a different location. Some agencies don't allow it, so you just copy it. Also, we want to encourage you to put your questions in the Q&A. If you look down at the bottom of your screen, there is a little square with a question mark that says Q&A. If you don't see it, click on the circle that says more, and you'll be able to find it in there and click on it. Once you click on it, then it'll show up at the bottom and you can just go back to it. But put your questions there. It's easier for me to find them because then all I'm seeing is the questions instead of trying to find them in the chat. So just put them there and then I'll make sure that we're asking those of our presenter, okay? And I think that, oh, sorry, one more big announcement. In case you haven't read your emails lately, we are moving starting next month. We're moving these trainings, sorry, I can't talk today. Moving these trainings to the second Friday of the month. So starting in May, the training will be on May 8th, okay? And I know you're all used to Wednesdays, but we are switching to Fridays. We think this will be a much better time for everybody. So be aware of that. We'll be putting them in the emails. If you're not on our email list and you want to be, just email me, tell me what email address you want the flyers to come to, and I will get you added, okay? Great. I think that takes care of our announcements. I want to get going. I'm excited. We have just been really looking forward to this. Gabby and I both have had the privilege of doing trainings with Nate, and it's going to be so exciting. So we just want to introduce you to Nate Cottle. He has consented to come and share his wealth of knowledge with us today, and we really appreciate it. He's PhD, LCSW. We were just chatting about his extensive history with education and everything, and how he got where he is. And I didn't know that. It was very fascinating, his journey. So we trained with him with the ART model, and it's just been amazing. And so I'm excited to hear what he has to present to us today. So I'm going to turn the time over to Nate. Thank you for being here. We totally appreciate it so much. We know you're busy, but we'll let you have the rest of the time.
Thank you, Kelly. I greatly appreciate the opportunity to be here. I want to first start off by thanking both Kelly and Gabby for the work they do at CJC. It's amazing the things that they're already involved in. And above and beyond that, the resource they are to our community to allow us to be able to have opportunities like this and to be able to engage in those. So, really grateful for the opportunity to be here. I'm not one for introductions. I really hate introductions. So thank you for doing that so quickly because it's painful sometimes to sit through. Um, I'm amazed at the numbers. I had planned maybe a small group interaction, and then when I found out there might be 300 to 400 of us, I thought, well, maybe we'll just pivot a little bit from that. Um, but just grateful for the opportunity to talk with you today, and I'm going to by the end of this make our slides available to everyone. Um, but I do kind of hope that we're provoking you a little bit with the title of the presentation. Um, it is important to me that we focus on a little bit on our practice and the way this came up, I think, was just in working with trauma trainings and other things and working with people. Sometimes I came on the analogy of how often we stir the soup. And as a therapist, sometimes it feels like we're having conversations and it's, oh, there's a potato and there's a noodle and there's a piece of chicken. And it's something that goes around and around. And it's something that we experienced over and over without necessarily getting to the bottom of things or resolving things. And that really can be frustrating at times for individuals, for those that we work with. And I really wondered, am I truly helping individuals? It reminds me of an early supervision I have with my first supervisor as I was meeting with patients. I had done an intake and I sat down with him and we were talking and he said, "Well, what's the trauma?" And I said, "There wasn't a trauma. It was just someone being anxious or depressed or, here's what's going on." And he said, "Well, I don't know that you've asked enough questions. I don't know if you've gotten deep enough with this person to make that judgment." And so, sure enough, at the next session, as we're sitting there talking, I ask, like, what are some of the things that are behind this? And suddenly there was one thing or another that would come up, and I noted in subsequent supervisions the statement became, it's always trauma. There's always trauma. And so as I got involved in clinical work, I started gravitating very quickly to trauma treatments and just wanted to be prepared to help as many people as possible because trauma is one of those things that I think we experience or we find people on a daily basis who need help to work their way through it. I also think as I reflect on, we very quickly moved to some of those diagnoses that we were given in our DSM classes way back when. And as we looked at PTSD, criterion A, it has to be life-threatening or it has to be something you've experienced or a close family member. And there were all of these restrictions that if it wasn't this, then it couldn't be PTSD, which I understand. There's a reason for that diagnosis. There's a reason for criterion. And I think sometimes there are traumas that are not diagnosable as PTSD. Traumas are something that occur perhaps fairly often in people's lives. And I'll explain that as we're going through. But let's dive in. Let's get going and let's talk about things. I definitely want to honor um, any questions you have, and so I've asked both Kelly and Gabby if there are questions that are relevant to what we're talking about at the time. Dive in, jump in, pause, get me to stop, and let's answer those because I think it's important for us to honor those and to think about those, um, just to make sure that we're on the same page. So, all right. So if we get started, I I provided a couple of learning objectives, and I think it's important for us to know where we're headed and what we're doing. First thing that we want to do, I've kind of have three small parts that we're going to be talking about as we go through this. We're going to review the HPA axis or the human stress response system, and I'm going to try and share a way with you, maybe to share it with your patients in a way that could be helpful to them. And then we're going to talk a little bit about polyvagal theory, which is, I guess, now controversial as of February. Some of the new research coming out, maybe questioning that, and Stephen Porges obviously defending his theory. But I think that there is value in explaining that. And then we're going to talk a little bit about trauma treatments and how to go about maybe trauma in an ethical way. So those are the kind of the way that we're going to go about things, and kind of pass through them. The last two are that we're going to compare and contrast top down versus bottom up. That's kind of not a new phraseology, but as we have developed more of these bottom up therapies to treat trauma, there's a clear distinction between what we would call traditional, more talk therapies and more subcortical trauma treatments. And I have found so much value in treating trauma, both using both approaches, but using the right approach for the right person. And so that's where the ethics come into this. Are we using the right approach? Are we doing it in a way that's going to be positive for them, or is there a better approach that we could take? And the last one is I'm going to make the suggestion that we ought to be doing more bottom-up approaches to intervene with trauma treatments, only because it offers us so much more power in maybe addressing it in a controlled way and even getting to the point of re-scripting. And that's really where individuals might find uh, true healing and be able to move on from some of these traumatic events. And so we're going to talk about maybe the justification for that and the reason for that. So glad you're here, glad you're on board. I want to start off kind of with just a question. And I think that there is value in doing this. So I recognize we have the Q&A, but I would like to use the chat for a minute. And I just want you to type into the chat, trauma is what? And I'm going to be interested to see some of those responses. I love it. I love it. Yeah, definitely trauma is a common thing, something that could be happening that could cause uh, a variety of things. So I like the idea of focusing on the reaction that we have to something, the dysregulation that we're experiencing. One thing that I might want to challenge a little bit is often we think of trauma as an event. And I want to challenge that a little bit because the event itself may have been adverse, but it may not necessarily be a trauma. And the reason we know this is that two people can experience the same event. One can be traumatized and one may not be. And the reason for that is not the experience itself, but how a person encodes that and how it's recorded. And so, if I can offer a definition of trauma for you, I think the definition I would give you is I've settled on it's a maladaptive encoding of an adverse life event, meaning that the brain and the body isn't able to maybe process it exactly how it would like to. And then the brain gets stuck. And so that's why I've put hashtag brain stuck. It's not my word. I got it from a colleague who works in trauma treatment, and just understanding that a person's brain is stuck, which means by default, their body is also stuck, because the brain is turning on the body, and that autonomic response is coming back and causing some of those things. So trauma creates both physiological and psychological changes in the system. It's not just the memory, it is the reaction to the memory. One of the original trainings I attended from the Arizona Trauma Institute talked about um, the someone experiencing a bear attack, and that is definitely a traumatic event, and it could lead to trauma. The difference is, and what the principle that he taught was sometimes the bear is here and sometimes the bear is not here, but I still feel like it is. And that's that trauma, that somatic response that we see in individuals that can be so troublesome and so much that we have to engage with. When we think about trauma, we have to think about our brain functioning, because there are parts of our brain that are assigned to work with trauma, and that those parts kind of take over when we're having that response to trauma. So much so that we may shut down all the way together. And so there's definitely a brain element to what we're doing. But then there's also a body element, the emotional regulation. When we are overwhelmed and our capacity is just tapped with what's going on, our trauma response might be just to overreact, um, to shut down, to turn off, to fight, flight, freeze, whatever that survival instinct is, we're going to have to deal with. And that's why we have to understand that we're not only dealing with the body, but we are dealing with the systems of the body. And so we have to look at the hormones, the stress response that we have, and how to go about that perhaps in the best way for us, but also for other individuals. And we want to talk about how to be with someone in that traumatic experience, um, and how to talk about it. So think of it as our brain being stuck and understanding that it's feeling like the bear is there, even if the bear is not. And it's important for us to understand that as a concept. When it comes to trauma, it's very important that we look at a variety of factors, because there's a variety of factors that can affect whether or not trauma impacts us and how great the impact is. First and foremost is the nature of the trauma. We know from the PTSD diagnosis, from other things, the closer something is to us interpersonally, the greater the impact it has on us. If we watch something that happens to someone else, it may not have quite the impact on us that it might if it is something that we've personally experienced or it's a close family member. If we have a vested interest in it, it tends to affect us more. Trauma from those that we care so much about. I saw someone put the word attachment. If we look at traumas caused by maybe that key person in our lives, those can be so much more impactful than traumas that might be more external to us. Especially if the trauma is someone who is in my home that I see on a regular basis or I experience over and over again. Second, we have to consider the dose. When we think about the dose of trauma, it could be that could just be the length of time that it occurs, but it also could be the depth that it achieves. Um, Certainly, certain activities, sexual abuse, some of those things are going to be much deeper um, than perhaps emotional abuse might be, but still those hurts might be just as great. And so we kind of have to be aware of what is the dose? Is this an ongoing thing? Is this a one-time thing? Is it, how impactful might it be? Because that might help determine what's going on. And then we have to look at the timing. Clearly, we know from the research that things that happen earlier have a longer time frame to reverberate and to cause more and more damage and greater hurts across time. And we also know that if things occur during critical periods, they could have an impact. So, for example, trauma that occurs as language is being acquired, that could have huge impacts on language development. And so individuals may be able to develop those language skills, or they may be limited in them for a variety of reasons, just based on the timing of that critical window. And so we want to look at those that research, such as on ACEs, as an example. The ACEs research clearly shows us that individuals who experience trauma in those minor years, that can have huge impacts. Just reviewing that the other day, seeing that the span of life, that people can lose 10 to 15 years of their life due to the health impacts of trauma. Um, I can't tell you, and I'm sure you've experienced this, the number of patients who have a trauma history and the correlation that we see with autoimmune diseases, whether it's things like fibromyalgia or irritable bowel or other diseases where a trauma has resulted in health impacts with a diagnosis, and it could be subtle things that we don't see, such as heart disease and other things. It shows up in suicidal ideation and a variety of different ways. So we are aware, and we can thank our medical community for doing that study. And what's interesting is they came up with the five, or I mean, excuse me, the five abuse and the five kind of factors that are in your home in the ACEs study. But the people behind the study said actually there were probably 20 to 30 that we could have listed. And so we could have had ACEs scores from a variety of things, but let's just stick with the top 10 or the most common 10, or those that we can package really nicely into an infographic. Um, but there are other things that might have happened early on that could be just as traumatic as any one of the other ACEs. And so it's really important that we understand that trauma can have a lasting impact, and that lasting impact may not just be in the mind. It can show up in health, it can show up in education, it can show up in a variety of things. And so it's really important that we consider the impact that trauma may have on an individual and on the pathway. One thing to be aware of that I think that we have to see, and I'm sure you've seen it in your patients, those that have experienced previous trauma are even more prone to having similar reactions in the future. And so they may be re-experiencing things that might be related to a past trauma, but they're more easily activated, more easily caught up by external factors, or even those external stimuli that might just remind them of something in their past. And so it may have both a physical health and an emotional health impact that has a long-term impact that we have to consider. When we think about trauma, I think we have to talk about the brain, and we have to understand that trauma impacts the brain in a variety of ways. The first way, and the term that we want to think about is kind of the neocortical part of our brain, that part of our brain that was, from an evolutionary standpoint, the newest, the human part of us, is that neocortical area that kind of covers our brain. And And the most important part of that might be our prefrontal cortex, where we have our rational thought, our planning, our decision making. And that is part of our brain that kind of goes offline. It has to go offline in order for us to have some of the more based, the more, I don't know, animalistic responses that we have in our limbic system, um, to help us, our fight or flight responses, some of those other things, even getting into our brainstem, where those survival things are kicking in as a means of helping us to survive and to overcome those things. So, as we think about that prefrontal cortex, that is a part of our brain that might shut down in the therapy setting as people are thinking about, talking about, processing through traumatic experiences. We can even see patients flood. We can see that part of their brain shut off, and they might disassociate. They might become combative. They might struggle in that setting as they are experiencing the bear attack in your office. And it's important for us to understand and to be trauma informed, to recognize the trauma response, to not be caught off guard by it, to not be dysregulated by that, but to recognize it for what it is and then to know what to do with it. And so understanding that impact of trauma on the brain is so critical. We also have to understand the structures of the brain that might be play a greater role in the brain functioning, and that is or those are elements of our limbic system, especially our amygdala. The amygdala is someone told me maybe it's the smoke signal or the smoke alarm of the brain. And it's that part of our brain that as we are recording memories and as we are processing memories, it's the one that kind of kicks on and starts to pay attention to what's happening. Um, it's the part of our brain that says, hey, remember this really well because this is really important because it's traumatic. And as the amygdala does that, our memories are seared perhaps more strongly into the different parts of our brain, whether that's the visual parts, whether it's the olfactory parts, the smell, taste, the touch, kinesthetic, the sounds, the auditory. Those are all recorded on a heightened awareness. And that amygdala is responsible for saying, pay attention to it. I recently had a couple who was um, in my office to talk about a shooting that had taken place across the street that they had witnessed, and then the shooter or the victim of the shooting had come across and banged on their door to the point that they had retreated into a back room, a basement room. Um, the the guy had found his gun to, thinking I might need to protect my family. And so here is his wife and kids seeing him holding a firearm, someone banging on the door, and how traumatic that was for their whole family. Um, that imagery was so vivid as they talked about it and were able to kind of recall the memory. They talked about the things they saw, the things they heard, the smells that they had. And anytime we use those things to access those trauma memories, our patients begin to re-experience some of those things. And for a lot of approaches to trauma, that is of huge concern because the last thing we want to do as a therapist is re-traumatize our patients. And yet, that we'll see might be one of the key factors in actually getting to the trauma and doing something about it. And we'll talk about because that has to be done in a very controlled way. And we'll kind of highlight how that might happen and how to go about it. Um, The hippocampus is kind of the quarterback of memory. It is the part of our brain that maybe connects the different sets of neurons where everything might be stored. The visual, the kinesthetic, the motor cortex, the olfactory, all of those different senses, all of the different inputs, it puts or connects all of those neurons and says, hey, when you remember this, these are all the places in the brain that you need to go. When I talk about this in some of the trainings I do, I talk about ponytails. I'm a father of two daughters, and one of the hardest things to do as a dad was to figure out how to do their hair. And I mastered the single ponytail. No pigtails, no braiding. I could handle a ponytail. Those elastics that they give you are so breakable. I probably went through hundreds of those. But you had to get all of the memory together, all of the ponytail together, and none of the hair outstanding. And the reason for that is because you want the hair to look good. But the reason for that in a trauma treatment, the reason you want all of those different neurons, we know from, Bessel's book, the body keeps the score. Our memory is stored in different parts of the brain and even different parts of the body. And so we want to be aware of that. If you want to treat it, you want to treat it all. You can treat part of it. Um, Oftentimes, people may not have a conscious memory of what they've experienced, but their body has a memory. Their parts of their mind have a memory. And so, gathering that all together can be a helpful way to really address the trauma in a particular way that's going to be beneficial. That's going to help us to get that timestamp of those memories and help us to move and to be able to process it in a way that's going to help us to move forward. The last thing that we know is that we have to be aware of the body's reaction. And so, as a trauma-informed practitioner, you have to pay attention to um, the heart rate. Not that you can measure that, but you can generally see when someone's heart rate starts to become elevated, their breathing, those autonomic responses, that tells you clearly what they're experiencing and how to go about it. So we want to be aware of the brain, and then we want to be aware of the trauma response and how to go about working with someone who's having one of those. So here are just an image of some of those parts of our brain that we're really paying attention to. So our prefrontal cortex, that's up here in the front of our brain. That is responsible. That's that control mechanism that's responsible for that rational thought, all of those things that we highlighted before. Then we have our amygdala. That's the second picture. It's deep inside our brain, kind of at the front of the limbic system. That is that alarm system that tends to go off and tends to be activated when we're having a traumatic memory. One of the videos that I show in one of the trauma trainings that I do um, highlights how people have used the amygdala and even some of the hormones it releases as a way of treating it. They use propranolol working with people who have a spider aversion, and they do it by exposing them to the spiders. So you have to see it, you have to touch it, you have to trigger that trauma memory. And the hippocampus is the part of our brain that connects all of those things together. If they can trigger the memory, then they can do something about it. And you can literally edit traumatic memories using that process. And so the propranolol works on the amygdala and it does not allow the proteins that are secreted when that memory is kind of reconsolidated. It doesn't allow those panic and those fear memories be associated with that previous memory. And so when the person comes in the next day, they do not have the automatic response that they have had before. They're still leery of a spider, but eventually, after a short time frame, they are able to interact with the spider and not be afraid of it. And that's because of these brain structures that are tied up in what's going on. So we want to pay attention to how trauma is stored and how it might be stored differently than other memories. Because the amygdala is signaling that panic, it gets uh, a type of priority. Um, from the example I shared of the couple that I worked with, part of what they captured was on their Ring doorbell, which was activated by the motion that was outside. And it prioritizes, and the Ring doorbell will record when there is motion. The amygdala signals, hey, this is super important, and it turns on the recording in a unique way. And so our trauma memories are stored very differently than some of the day-to-day memories that we might have. And that's why they're so powerful. In fact, when I often will go looking for trauma to treat, I don't start in the past. I rarely ask people what traumatic, I do it in the intake. We always ask that question, what traumatic experiences have you had? But I don't try and access it. Hey, you said this. I feel like this trauma that you mentioned is probably the worst thing you've experienced. Let's work on that. I don't do that. I ask them in the current moment, what are you experiencing today? Where have you tripped up this week? And what's happening when you're being tripped up? And then I won't ask them what memory do you have of when you have tripped up this way before? I actually will make them sit in it a little bit. What did you see? What did you hear in that moment? What senses were going on? What sensations did you have in your body? Where were they? You literally have them sit in that experience for a few minutes. And as they do, they get a greater understanding of the feeling. They're almost activated right there in front of you, not to the extent that they're panicking, but they're really starting to think about and feel the bear's presence in that moment, even though they're not in a dangerous situation. And once they have that sense or that feeling, we ask them the question, when is an earlier time that you have experienced this same memory, this same feeling, this same sensation, this same experience? And their mind will go straight to it. But if I ask them, oh, so this thing that happened to you, when else have you had that? And if they go in their autobiographical mind, they won't be able to access it. If they're using that emotion, they know exactly when. Oh, it was this time. And it happened again before this time. This was the first time that it happened. I remember it clearly. And that's why we use the limbic system to access the memories that we want to work with. We don't use the prefrontal cortex. We have them feel it, experience it. The emotional reaction connects to the previous, not the logical. Okay, so if my boss yelled at me, that's probably like my dad yelling at me. So that's probably this experience. It's not brought up that way. It's brought up from the emotional response to the other emotional response. And sometimes, as clinicians, we get it wrong. I often share an example of someone who came in to work on some panic attacks and some traumas that he was experiencing on a daily basis before going to work. And he told me during the intake that he had had a history of sexual abuse by a neighbor over a 2 to 3 year period. And I thought, okay, we're going to have to work through that. And when I did that exercise of having him sit in this memory and to think about what is it that I just experienced? What am I feeling? What's going on when these panic attacks are happening? Where do I feel it? It's here in my chest. It's an increased heart rate. It's a weight on my chest. As I had him sit in it, I asked him, when is an earlier time that you had experienced this? Thinking maybe it goes back to that time he was raped by his neighbor. And no, it was when his third grade teacher said, I don't think you're going to amount to much in your life. And I asked him about that experience, and clearly that was a tipping point in his life, and he connected that to something that a ninth grade teacher said to him that, I again that I don't think you're going to amount to much. I don't know if you can do this math, and I don't know that you're going to be able to graduate. And that became a self-fulfilling prophecy. He didn't graduate from high school. He had to go back and get a GED because of those comments. But the traumatic response was a third grade teacher and a eighth grade teacher or a ninth grade teacher, the comments that they had made to him. And that's why he was having panic attacks. Not because he had been sexually assaulted multiple times by a neighbor over a 3-year period. The part of me that's the event part of me said it's got to be the worst event in his life, not the one that was actually the most impactful to him, because his mind had processed that sexual abuse in a way that allowed him to move on. That's why people can see something that's very traumatic. I don't want to say make sense of it, but for their body, they make sense of their reaction to it, and their brain is no longer stuck on it, and they're able to move forward in a healthier way. Other people can't do that. And so it's important for us just to be aware that response that a person might have, that emotional response, might connect to something that we don't think is truly traumatic, either as a big T or as a little t trauma. Um, Remember, it's not the event, it is the encoding of the event. And so if I encode an event where a teacher tells me you're not going to be much, and that becomes perhaps a core belief that I live out in my life, then when I'm 40 plus years old, I might be waking up every morning in a panic as I go to work every day because I don't know if I'm enough to do that. And it may not be the event that you would think, but it's the one that really needs to be worked on. So I just encourage you to use emotion as the way to connect to past, not emotion and sensation in the body, not autobiographical memory, because a lot of times that breaks down and people can't remember. That isn't something that's helpful for them. And the way to do that is just to have them sit in that memory for a minute. When we talk about the brain, we also have to talk about the difference between what we would call neocortical, that those upper layers, kind of the squiggly lines that we would see, the gray matter, and the subcortical areas that are down below, lower in our brain, the limbic system, the brain stem, because those areas are different. The neocortical area, that part of our brain differentiates us from the animal kingdom. It allows us to have a sense of self, language, to process things very differently than in the animal kingdom. That is that higher order processing, rational thought, the planning, the awareness. It is what goes offline when they're having a traumatic experience. Why? Because we can't make sense of what's happening and we shut it off in order to promote our survival. We immediately go to what I call the basement, and I'll kind of show that to you. Um, but the funny thing is, that's the part of our brain that we use in talk therapy. As we talk about what happened, as we remember, as we discuss it, it's definitely that prefrontal cortex that's kind of driving that. Um, it's not necessarily going to be helpful to get down to the deep sensation and the somatic experience that we've had. Sometimes we can get there, often we can't. And so we have to be aware of that. Um, Secondary to that, we also need to talk about or think about the the ability to use that part of our brain eventually, because an important part of recovering or an important part of overcoming things is to eventually get to a place where we can use that portion of our brain to make meaning of what's going on and to create a narrative that helps us to move forward in life. The subcortical parts, those structures that we have lower in our brain, we have to be aware of as well because they have a significant role in what they're doing. And that is going to drive our autonomic, our fight, freeze, faint, fawn reactions that we have to people and to situations. And it operates below that conscious awareness. It's that somatic experience that we're having. And it may require a bottom-up intervention to really address it. When I say bottom up, I want to be clear because we're going to learn that in the third wave of CBT therapies, the third wave really connected mindfulness with CBT, and it kind of integrated those two together. And it was a real attempt at doing a bottom-up approach. It's why we have something like TFCBT, trauma-focused cognitive behavioral therapy, because we're using mindfulness as that bottom-up piece. It's not exactly the same as a subcortical bottom-up approach, but it's adding a piece that helps us to work on the body. But remember, it's not just the body we have to calm, it's that limbic system, that lower part of our brain that we have to access. And that sometimes can be accessed in a little bit better way. And we'll kind of highlight some of the trauma treatments that allow us to do those things. So I want to talk about the HPA axis for a minute. The HPA axis is a unique part of our brain. We call it the stress response system or the human stress response. Um, and that HPA axis includes certain brain structures. The hypothalamus, which if we saw the amygdala, here in our brain, the hypothalamus is just kind of a little bit above that, a little bit above the hippocampus. And that hypothalamus is going to release a hormone that is going to stimulate the pituitary gland. And the pituitary gland is kind of that, I don't know, it's the gland of all glands. It's the control of the rest of our body. And so it will release a hormone, the CRH hormone, that will trick or encourage the pituitary gland to release the request to our adrenal glands for two separate hormones. We're going to release both adrenaline or epinephrine and cortisol. And those two are released in our bodies. The adrenaline, we probably know really well. It's that fast acting part that just goes straight to our heart rate, to our brainstem. It increases our heart rate, it increases our breathing. That helps us. If I need to run, I'm going to be prepared to run. If I need to fight, I'm going to be prepared to fight. That is probably the one that we start to feel the quickest because it's fast acting. The second one is cortisol, and that starts to affect our blood sugar. It tends to shut down digestion and it tends to put us on that okay, if we're doing this, let's stop doing some of those life things that we normally do. Let's just focus on the moment at hand. And so adrenaline and cortisol work together. The problem is that this response system is really good when we use it occasionally. If we're using this on an ongoing or a daily basis, we are triggering it so much that we start to become cortisol resistant. And when our body is not responding to cortisol, when our blood sugar isn't regulating with cortisol, the brain just has one solution. Let's just do more. And that leads to the inflammation that we see as we talk about some of the responses that we have. and some of those larger responses, that is where that level of cortisol leads to the inflammation and leads to some of the development of those diseases. So when a patient comes in and they say they have fibromyalgia, I pretty much guess they have a trauma background, and if we work on the trauma, we can actually improve a little bit of that reaction or the flare-ups of the fibromyalgia. Not that we're going to get rid of it, but that if the high cortisol level was something that helped trigger it, a lower cortisol level is something that will help diminish that in their lives. So the way that I share this with patients, and I'm just going to draw because that tends to work better. So forgive me, I'm not the world's greatest artist, but I'm just going to draw an image here. And I usually start with the image of a house. Okay. So here's our house. I hope you can all see that. This is our house. And in our house, we have an upstairs and a downstairs. And I like to think of the upstairs as the top part of our brain and the downstairs as the bottom part of our brain. If we think about the upstairs and downstairs, I would divide it into two. And I think there's a place in our brain where we focus on conscious thought and that rational thought. And so I'm going to put rational thought up here, and I'm going to call that the living room. Okay. And the living room that we have in our brain is that prefrontal cortex that we've been talking about. And that is super important for us. Um, but it's the first thing that goes. When we go to the basement, we lose access to that prefrontal cortex. The second part of our brain that we have that we really need, that's important to us, I think is what I would call empathy, or the ability um, to to take on an emotional perspective of another. And so that empathy, or that feeling component, oh, it's not letting me get it. That empathy, if you will, is the kitchen. That's where we go in the house to talk to each other, to relate to one another, to consider those things. Downstairs, if you think about the downstairs of your house, it may be this way, it may not, but downstairs we have the furnace, we have the water heater, we have maybe the cable, the electric box in that maintenance part of our house. And that is kind of like the brainstem that we have in our body. That runs everything in our house without us thinking about it. We turn the faucet on, there's hot water. We turn the light switch on, there's power. We get cold, our thermostat kicks on and the heat comes out. That's all done automatically for us because of what happens in the basement. Well, as soon as our basement starts to flood with these hormones that are being released, we go downstairs. And when we go downstairs, we leave behind our ability to think rationally and our ability to have empathy for other people. And so when I talk to patients about why is this person, why can't they see my perspective? I'll ask, are they in pain? And they'll say, well, what do you mean by that? Well, if they're in pain, this is their pain. And what do they see? I can see what's right here in front of me. I can't see you, can't see what you're experiencing because my pain is right here in front of me. And to consider that when their pain is maybe diminished or resolved, they can see what's going on. When our house isn't flooding and we're not downstairs and we're not trying to bail out these adrenaline and cortisol, we can go upstairs. But all we have downstairs is flight, fight, freeze, faint, fawn. Those survival instincts that keep us going. So we're in the basement, we have access to those. When we're upstairs, we have access to our rational thought and our empathy. If we're downstairs, we don't have access to them. It's not bad. It just means those aren't things that we have immediate access to. We do need a survival instinct. If a bear is attacking us, I want fight and flight. I want those to be at the forefront of what's going on. I don't want digestion to be, hey, I'm hungry right now. I don't have time to think that. I need to either run or play dead or do some combination of the both. I might need to fight, and I need that adrenaline to help me do things that I might not otherwise be able to do. So those are important parts of our brain. It's just we shouldn't be ready to fight the bear if the bear isn't here. If I'm having a response and feel like the bear's here, but it's not something that's going to help me, and I need to be conscious of that. So that's how I would use that. And often I will call being upstairs in your brain as being in the green, and being downstairs in in your brain as being in the red. And I can ask a patient, are you in the red or are you in the green? And it allows them to maybe access just their thought process around that. We know as a trauma-informed provider that if someone's in the red, if they are experiencing some of these things, we have to use something like mindfulness or some tactic to help them to calm down and to move back into that space, especially if I want them to have rational thought or to have empathy. And so as we help our patients to understand maybe what's going on in their body, when this drip is going on of this adrenaline that just kind of won't shut off, as this cortisol is just causing the inflammation and pain throughout their body, that's why. It's because we've turned it off and on too many times that the switch doesn't fully work. And that can be achieved over a prolonged period of time by first maybe addressing some of the trauma and addressing coping skills to help them. Hey, when I feel that drip, I can do something about it. And so we teach people how to engage in those things. So that's the HPA access. And I think it's vital that we understand that, that we're able to kind of work through that and to help our people to be able to do that. I told Kelly and Gabby that we would take a break, and certainly want to honor that. Since we're at an hour in, we're going to take about a 10-minute break and come back at 10 after. So if you would like to stay in the meeting, you can just put your camera off or mute and do what you need to do. But let's start back in about 10 minutes. Sound good to everyone?
That sounds great. Nate, I was just gonna let you know, we have about 3 questions in the Q&A. So if you want to look at those during that time
Sure.
and then give me a
Absolutely.
time when we
I
come
will
back.
take a look at those and maybe we'll come back and address those as we're
Okay,
going.
great. Okay, we'll see you back in 10 minutes.
All right. I got into the questions and they're so good. I've been answering some of them, typing them out, and I'll spend some time even after answering them if I don't get to them. I have
Okay.
answered about six of them. Yeah,
Can
go
I just
ahead.
take 1 minute before we get started
Oh,
again?
please do your announcement.
No, 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 you're fine. You're fine. I'm getting some comments. I'm reminding you all that that evaluation link will be put in the chat at the end of the program. So start watching for that about the last 15 minutes, and you can just click on that and to get your CEUs. And if you want the slides, you're not planning on filling in, you don't need the CEUs, you're not planning on filling out an eval, then just email me or Gabby, and we'll make sure that you get those slides.
I'll also try and put them in the chat. It's tough to talk and move things at the same time, but I will have that done.
No,
So
you're great. Thank you. Okay.
okay, so just looking at some of the questions, and I've answered some of them. Do I think EMDR as a modality to treat trauma is effective because of the desensitization of traumatic memories? Absolutely. And we'll see in the discussion that there are elements of EMDR that are neocortical. They are, as we think about holding together the problematic belief and the new belief, those are both language based. And so they tend to be in the prefrontal cortex. And so I list EMDR as a bottom up approach. I'm going to put an asterisk there just because that element does not sit well with me because we're trying to mix subcortical with neocortical and there's a little bit of confrontation. I think if you take people deeper and stay subcortical, you do a little bit better. Um, when I say sit in the memory for a few minutes, what I do mean is in the present memory. So if you are sitting in a memory trying to recall maybe a past trauma, you spend time in what happened this week, how did it feel, were you experiencing, where was it in your body? Now that you're feeling that, go back to the past. When have you felt that way before? So it's really sitting in the current memory to recreate the emotion, not to re-traumatize, but to just experience it to a greater extent. And then that will help them connect. There's also a great question. I appreciate Ro. Talks about both the salience network and the RAS. I did not include them. There's so much to talk about. Um, but these are very important brain structures in the recognition of trauma, and those are clearly part of that trauma response. Um, the anterior insula and the anterior cingulate cortex are other parts of the brain that are deeply involved in this. I did not cover them. Um, you can get into it. It certainly helps explain hypervigilance, seeing or paying attention to certain cues, whether that's visual or auditory, smell, whatever. That is something that we're going to see in neuroception, which is right on. It's the kind of the same thing where those mirror neurons are looking for danger and they're recognizing and they're tuned into, okay, if I get this look, I know abuse is coming. If this is happening, I know. So that's when I'm gearing up for those things, which is great because it goes into the next question about fawning. Is that response? Is there some type of thought process behind that? And I totally agree that there is. Um, I do think that these survival instincts, these are strategies. And I think that there is a part of our brain that says, that still works in, okay, what can I do to survive? Do I, there's a decision. Do I fight or do I flee? Am I running away? Am I taking flight? Do I fawn as a way of let's just get this over with and we can live another day? Definitely feel like there are strategies and there is calculation in that. So part of that might be neocortical. So I agree with you. Can trauma be rooted in long-standing patterns of extreme negative self-talk? In other words, can you traumatize yourself? I definitely think so. I've had some clients who, even in session, as they start to talk and as they get into these loops, I supervise someone right now. He will actually physically start to harm himself, to hit himself. And that's it's a trauma response. It is a fight, but it's a fight myself. And I think you can see that in a number of people. So it's not quite the same as maybe self-harm, the way we're thinking of like NSSI, but it is a form of just kind of those trauma responses taking over. And will I go into some of these trauma-based approach? Yes, I'm just going to do a summary. I don't want to tell you how to do therapy. You get to choose how to do that. I'm going to tell you some things that I've learned and some lessons that I've taken from it, and you get to make some decisions on your own. And there's more questions there. I will get to those, and I promise I'll answer them so that there's at least something that shows an access so that you can go back to this and gain from those. So appreciate those questions, and I think you're right on. And I see there'll even be more. So now that we've not encouraged the behavior, but we've talked about it, feel free to ask those questions because that is important for us to help you to get to where you are. Um, in February, everything kind of got topsy-turvy for polyvagal theory. There was a paper that was published where 39 brain neurologists said we disagree with Stephen Porges and the polyvagal theory. We disagree with the three components. Stephen has responded. We're kind of now at this impasse of, well, that's what you said. That's not exactly the theory. What you're saying is something different. And agree to disagree is kind of where we're at right now. But I do want to pay a little bit of attention to polyvagal. I think that there is value in this, in discussing it. Just understanding that that vagal nerve, the vagus nerve, does connect to our heart, our lungs, our digestion, and a variety of parts of our trunk in our body, and that there are elements of that that are um, activated. One of the things that's interesting is I always have a discussion with people, and we're really great at teaching box breathing. Box breathing is great, you know, 4 in, 4 out, 4 in, 4 out, and it makes sense. And then I watched a podcast where they said actually we show that box breathing causes more anxiety than just breathing normally. And I was kind of caught off guard by that because some people are maybe so caught up in the counting that they forget some of the other things. And so one of the suggestions that I've learned and paid attention to is kind of this two-part breathing where you take the deepest breath that is possible through your mouth or nose. So inhale, and and your lungs are full, and then you take one more small hit that just pushes. And the interesting thing about that deep belly breathing, or that the purpose is to push on that vagal nerve and to turn on that response. And so two of those breaths can be way better than 5-10 minutes of box breathing for individuals. And so I'll use that and teach that as something to be able to do. And if you don't watch the Huberman podcast, I'd strongly encourage you to do so. He gets into a variety of behavioral things, and there's a lot there that you can learn from that. But the polyvagal theory suggests that there's parts of our nervous system. We know the parasympathetic and the sympathetic, and we've paid attention to them, but that there is perhaps this third element that we're going to call ventral vagal. That is the social connection. So when we're feeling good, we actually seek this social connection with other people. And so the brain kind of has this ventral vagal. This approach is the social engagement. It's kind of the face and the voice. It's the parasympathetic part that calms us down. And that can be something that's really important to us. Then we've got the sympathetic. That is our fight flight. That's our mobilization. That's the adrenaline. That's get up and go sort of thing. And then what they call the dorsal vagal, and I think this is where the criticism is coming in that there aren't actually differentiation in neurons, and so that this can't maybe exist because those differentiations aren't there. But as a conceptual model, there's somewhat that makes sense that we might go from ventral vagal where we're good to fight or flight, and then we become overwhelmed to where we might shut down or freeze to where we lose that functioning ability altogether. And just understanding that those elements or parts of our body or brain might be there, and that there might be elements of that we have to pay attention to. So ventral vagal is kind of that state we want to get people in um, as a means of kind of functioning for a where they can engage with other people. They aren't hyper vigilant. They aren't looking for. They're not having that trauma response. They're not, as one client put it, in the tornado. That they can be present with themselves and feel good. That dorsal vagal, sometimes we see that with disassociation, with shutting down, where I like to think of it as a circuit breaker in the brain where I just can't, the threat is too much, that I just lose functioning altogether. And so those are the elements of polyvagal theory. Um, the idea is that the higher up we are, the greater our functioning level is, the more we can engage in the social engagement and some of those things as we start to feel the danger because we have these mirror neurons that are looking out. We have twice as many neurons looking out as looking in. And so we start to pay attention. We see it all the time. And we've been told and trained as clinicians, watch your facial expressions, watch your reactions because your clients are seeing that. How many of us have indirectly just kind of glanced at the clock and then our patient sees that and is like, oh, I've got to hurry, or I'm sorry, the time is going by. It wasn't our intention to communicate that, but they are paying attention to everything that's going on. It may be that first appointment after lunch where I just want to yawn, but if I do, are they going to perceive me as, hey, he's just doesn't care about me. He's yawning, he's disinterested. Remember that as we engage these different parts of the polyvagal theory or at these different states, we might have different access to different things and lose access to other things. And that's the important part is that trauma response. I'm using the word activation. I'm avoiding the word trigger on purpose. I like the thinking of activation better than trigger. But I can sense that, I can feel that activation, and I can do something about it. It's not something that just controls me, and I have no choice in this. I have a choice up to a time frame, and then I might become overwhelmed, and then I start to be at the mercy of other parts of my brain. So this neuroception is kind of our internal radar. It's us looking out and monitoring danger. We're looking at other people, paying attention to their facial expressions, their body language. That is why, as therapists, we need to regulate, that we need to be present and not respond or react to what people say to us. We also are scanning the environment. Is this a safe place? It's why we don't sit maybe between the door and our patient um, who has a trauma response. It's better to orient your room to where you're not blocking the door from someone that if they wanted to, they could get up and leave. But if you block the door, now suddenly there's added stress. Even though what might be going on isn't stressful, it's something to pay attention to. So we're constantly, am I safe? Am I not? And someone who is experiencing hypervigilance is doing that to the nth degree. And so we really want to pay attention to that. Are we paying attention to the cues of safety or the cues of danger? And what do we see in our patient? We have to be aware of those cues, like what's happening. Is the posture open? Are they protecting their organs? Are they covering vital parts of their body? Are their hands in their face? Are we touching our face? Are we signaling to them oh, that's stressful what you just said? Um, so we have to notice those things and recognize our patient is going to know what we're doing, regardless of whether we're aware of it or not. And that's why sometimes just watching a video of yourself as you interact. Often I will have supervisees now that we're, required to do direct observation. I'll have them record a session with permission, of course, but just maybe of their reactions. And I'll have them watch and see, okay, did you see that response that you had there and talk about what that might communicate to someone. So we just want to pay attention to all of that. Understand that teaching someone to regulate their emotions is so big. Whenever we talk about trauma treatment, we want to first emphasize stability, and we want to help them to be stable, to feel safe and build on that. That is where we want to focus. And so those mirror neurons are looking out and they're communicating. We're communicating to our patients, they're communicating to us. Unfortunately, self-regulation is something that they're going to struggle with because of the hurts and harms. And so we might need to co-regulate. That's why it's so important for us to regulate our emotions, to put ourselves in a calm state so that they can borrow that calm energy from us. One way to do that, one that I've heard along the way that has helped me immensely, is muscle relaxation. To be able to kind of not something your patient can see, but just to pay attention to the muscles in my body, like just kind of maybe flexing, holding them for a second, and then releasing them, might be able to allow me the ability just to kind of move through something in a way that calms me down. And so the person that suggested it, he said one of the parts of our body that we can um, use is our I guess you would call it our pelvic floor. We can clench and release our pelvic floor, and in a way that's not super obvious to a patient, but that's a muscle group that we can flex and let go of as a way of calming ourselves. And so I thought it was interesting that he used muscle relaxation as a way of doing that. Remember, when someone's experiencing something, language isn't necessarily our best friend. They're overstimulated. Sometimes just that calm presence can be so much more than I'm here with you. You're going to be okay. Calm down. Like trying to talk them through it is not necessarily the thing that we might need to do. I might need to be quiet and present and just hear for them in a way that's calming, not um, you know, getting upset or worried myself. And so we need to work on that as clinicians to be able to engage that. Understand the second half of this, I think, is super important. Understand that mental illness often is a stuck nervous system. So they're stuck in a state or they're brought to that state very quickly and they're not able to necessarily leave that state. Those symptoms are the adaptive strategies that they have to deal with what they're doing and making sense of what's going on. That is part of therapy, is showing them a better way, training their body, training their brain to a different way of reaction. Here's a new strategy. Let's try this instead. This might work a little bit better. And so we always search for connection before seeking insight and safety before being able to process trauma. Super important that we're aware of that and that we can reduce the shame that someone might have because of an inability to regulate their emotion. So it's super important that we figure out how to do that. So I want to get into the trauma approaches because as soon as I learned that trauma was the thing, and I had to, as a therapist, I had to learn, and I couldn't just sit and stir the soup. And have a patient come back every day and every week and say, yeah, it happened again and it happened again. And we're not doing anything to kind of decrease that. That was really frustrating to me. And so I did what we all do. We went and got additional education and we started learning ourselves. And I went to just about every trauma training I could find and really engaged with them. And what I found was slowly but surely, I recognized the bottom-up approaches have a much better approach to trauma than some of the top-down approaches. And I almost wish we would integrate bottom-up approaches in graduate school so that new therapists are coming out with it. Often when I train, I have interns, and I think that's awesome. Um, when when I started training and different trauma approaches, it was about the time my daughter was graduating, and I said, "Hey, you're going to be in this training before you start your internship." And I trained her in ART so that she would be able to engage, and she uses it on a daily basis. And now she's in a PHP, which I heard got changed to HIOP. Um, where a day treatment program where she has to help people to regulate. And she uses some of the techniques that she used there and she uses it in her individual sessions. So I think it's important to grab that additional education as much as possible. So let's talk about top-down approaches. Really, the focus here is on the cognitive processing to understand, to be consciously aware. And so we're talking about the narrative. If it's linguistic, it's going to be in our prefrontal cortex. We're thinking of the language, the words. That is so much stronger in our neocortex than things like images. Images are something that we can experience subcortically and deal with subcortically. Um, so the work in this top-down approach is working on the thoughts, the beliefs, the emotions that we tell ourselves. Cognitive behavioral therapy for a lot of them. It does build understanding and coping. We can work on skill-based and other things. We can start to create narratives and think about meaning making. So you could use TFCBT. I love how it combines both artistic and as you're working on a trauma narrative, there's linguistic and artistic. You're trying to engage multiple parts of your brain. CPT, kind of one, a little bit controversial. IFS, not controversial in an approach, but a lot of people love that as a trauma approach. I think there are elements that are wonderful for it, but we have to understand it's a top-down approach. We're talking about language and understanding parts of us and talking about how those parts might have experienced something. I think you have to pair it. And so I found a lot of people who are IFS trained love learning something like ART, brain spotting, something where they can access a subcortical approach and put the two together. And I think that they work together super well. Narrative therapy, psychodynamic. The limitation I want people to understand is that when they start to experience the trauma, when they start to be activated, sometimes that part of their brain, the prefrontal cortex, goes offline. And it's really tough to talk about something when I'm experiencing it. And I have to be able to experience it, calm it. That's why third wave CBT integrated mindfulness. What they learned was we can't just talk your way out of it. We also have to experience your way out of it. So if you are using a top-down approach, you have to have a bottom up, a mindfulness, a somatic type way of calming the body because it's the calm body that matters so much as we are reprocessing, as we are maybe creating that different narrative. And I'll highlight in just a second who I think these approaches might be best for. The bottom up approaches are going to target the nervous system directly, and it's going to focus on the sensation and the implicit memory. It's going to bypass the conscious, the cognitive processing to get to that subcortical level. And that's really what we want is to address it where it's happening. Um, and it's kind of interesting. It is a purposeful and controlled activation. The reason you need the activation is because you have to access the memory in its entirety. And so you almost have to activate someone to be able to help them. But you have to be a skilled clinician. You have to have an approach that allows you to do that, but to do it safely. When I was first trained in EMDR, that was almost forbidden. It was be careful, like you do not want to do this. And so we use things like a safe place or a box or container that we can store in. Like there's a lot of concern, care and concern in that second level. We're gonna focus on that to be able to do that. One of the things that I've liked about ART is I am very comfortable in working with ART with people. I can activate them. I can have them experience perhaps their worst moment, but I can do it in segments that are short so they don't flood. And then I can immediately switch to using bilateral stimulation in one form or another to calm them down. So it's let's take a chunk, let's calm it down. Let's take a chunk, let's calm it down. The other piece that I think is really important is that there's starting to be a rescripting. So the couple that I worked with the shooting, and I worked with one and the other was right there, and then we switched places on the couch and we worked with the second one. Um, I talked to her just the other day and I said, "How are you doing?" Because this was within the last couple of weeks. She said, I saw three or four things that would have brought something up, but immediately I went to this image of this meadow that I had in my mind. And so I've been spending some time in my meadow and things have been great. And my kids are doing so much better because they see me calm. They see their dad calm. The guns are put away. The the knock at the door isn't as activating as it's always been. Um, I'm just existing in my meadow. And that was super empowering to me. The asterisks that I have by EMDR, the kind of juxtaposing, hold the negative belief and the new positive belief, holding those two together, that's a neocortical approach. I wish it weren't language based. I wish it were because you do have the image and you are using bilateral stimulation. I just don't like switching from a subcortical to a cortical. Holding words in your mind is something that tends to bring you up. But we know we have a monumental evidence base that EMDR works. ART, I think a lot of people who train in it, like I started with EMDR, I did brain spotting, I landed on ART. I do train in ART as full disclosure, but I do it because I find it to be the most effective, the quickest, the easiest, and perhaps the safest approach. There are times when I'll use brain spotting, but I really haven't gone back to EMDR as a means in probably 3 to 4 years because I've found just this has been more effective. But then there are people who do somatic experiencing or somatic. There are other approaches that aren't listed here. The key is they start subcortical, they stay subcortical. You can switch. The next session could be a talk therapy, could be a cognitive approach. In fact, I think there's way more on the next slide. It's way more effective to use both bottom up and top down, but to use the right one for doing the thing that you want to do. I would not want to use a language based where I'm working with someone and activate them because that part of their brain is going to shut off. And if I don't have something to calm them down, that could be something that's troubling. So anything that's working in that limbic system, in the brainstem, um, that isn't using language, isn't using rational thought, is going to be super helpful. The bottom-up approaches can access those memories directly. They can also control the activation, the access to the memory. And then the piece that I think is missing in so many, they can re-script it in a way that once that memory reconsolidates, that window is closed, the elements that were so troublesome can literally be stripped out of the memory. And so we see people improving so significantly. That's why in the comparison study that was done at Walter Reed between CPT and um, ART, the researcher was, they said that ART had this huge dropout rate of patients. And they said, if you're not doing 5 sessions, then that's a dropout. And the people who are doing ART said our patients are better after 2 or 3 sessions. The dropout isn't because it didn't work. It worked so well that they're not needing to come back. And they said, well, we can't differentiate that. And they said, let us give us the names. We'll go find them and we'll assess that. And the PI on the study is actually the author of CPT, and there's no way she wanted that to happen. And so she just said, "Oh, I'll just say they're equivalent to one another. Let's move on." Um, and so that study, she never published it, and so it's hanging out there. The data's out there, uh, but there's really a powerful thing. I know because I heard from an independent source that the Veterans Administration tried to buy ART from the creator and said, "Hey, I'd love to, we'd love to have this so that we can use it." And you know, eventually, hopefully, we'll have the research base to go behind it, similar to what EMDR has. Just the different approaches, the top down. If it's language based, if we're focusing on beliefs, if we're doing the narrative sort of thing, that is a conscious processing. Meaning making, that's a big part of that. That's great, but it's tough to access that limbic system, that brainstem, unless we're really well equipped at pulling in mindfulness and other calming techniques. You've got to be skilled in doing that. Um, it may work for some people who might be a little bit higher functioning or who might have processed some of the emotional part of it and now need to deal with some of the language or the core belief elements of that. The somatic approach just gets straight to that body piece, and like brain spotting. I didn't mention this, but brain spotting just uses fixed kind of fixed mindfulness on a particular spot. And so just holding there allows someone to have a somatic experience, a emotional, just kind of an experience without even saying anything or doing anything. And then once that experience is over, then maybe talking about it or processing through things. Um, I would suggest to you, and this is where the ethical part comes in. The best practices are probably to combine some element of that, but to use the right one to do the right thing. Um, you're going to get a lot out of towards the end of therapy with that meaning making, with that narrative approach. And if we're talking about post-traumatic growth, that is a huge thing where we need this part of our brain to think through it. But if I'm right on the edge and I'm experiencing those trauma reactions, that subcortical approach, that bottom-up approach is going to get that and access that and let the air out of that so that some of the other things can take place. So you need to match the approach to the trauma type, the client readiness, the way they present in front of you. Just if you know that the window of tolerance is being threatened, if they are outside of their capacity, you know that that's not a place where we can deal with this from a cortical or from a prefrontal cortex kind of side. So if a person has strong cognitive abilities, if there's some safety that they already have, if they're working on meaning making or verbal processing, use that top-down approach. I think it can be super helpful. When you would you want to use the bottom up? If it's visual, if it's strong, if there's a strong somatic response, if the symptoms are very strong or they have difficulty talking about it, so much better to use bilateral stimulation, some sort of mindfulness, some sort of calming to help kind of work through that. And if it has a way of maybe rescripting it, it can be super effective. And so the point is, you have to be multiple. As a provider, you need to be able to engage in more. More is better than fewer tools. Um, and I remember talking with one therapist who's like, "This is my model. This is all I use." And when I ask, "Well, what happens when your patient doesn't fit your model?" And the response was that that person probably that's probably a referral I need to make. And I understand that. That was the thought process of if you want to do Freud, you go and study with Freud. I don't think we have the luxury of doing that today. We don't know who's going to walk in. We don't know how a person might need to be approached differently. Um, a concept such as neurodiversity. Um,
Huh?
if someone's neurodiverse, that might be something where we have to consider how do we go about that? What approach might be best for someone who is maybe less verbal? I notice when I call it, forgive me, I call it the F word when I'm working with someone who might be neurodiverse on the spectrum, and I say, "What are you feeling?" They're like, "Nothing." I get a response that that feeling word, just I can't use it. And so we have to talk about what sensations are in your body, what's your body experiencing. It's not a tingly feeling. It's not necessarily an emotional word. It is a sensation, and that helps significantly in doing that. Um, I do have a small case study that I'm going to share with you. I did want to take some time to have it be a little bit more interactive, but with 400 people, that's not going to be possible. But if you were to think about someone who was coming for anxiety or chronic pain, um, into your office, especially someone who belongs to a marginalized population or an underserved population, who has maybe received talk therapy for 2 years and has some improvement, but still is experiencing the panic attacks, the somatic experiencing the trauma response. What do you do in that case? And the key here is if they're starting to have that trauma experience in front of you, you have to have the tools that will help them to calm down. So if you're a talk therapist, you better have some really strong mindfulness skills, some really good interventions to help someone to calm down, to think about whether that's a pendulation, whether that's a safe place, whether that's a container, whether that's um, vergence or any of those muscle relaxation, guided imagery, whatever it is, you need to be well versed and multiple in helping someone to calm down. If you are someone who has some form of advanced clinical training in a trauma-based approach, you can use that. But you definitely need something that's going to help the individual to regulate. Um, Certainly, we don't want to activate without an ability to regulate. And that's one of the first things that I work with people. Can we regulate? And if I know this can be their worst, and I can help calm them down, their confidence in the process goes through the roof. If it's, hey, whatever you got that's bad, we know how to deal with it now. As soon as people will do that, they come with a list of, hey, here's another thing I want to work on. Here's another thing. And so just having those tools, you don't have to be the world's greatest therapist. You just have to have the right tools to address the problem. And you can be super successful in doing that. I see that there are a few more questions. I want to end with a few minutes and maybe take some time to kind of go through those. So let me pull those questions up and talk a little bit through them. So we have the ones that are previously answered, and I hope I addressed that. There's still 8 that are out here. Can someone who has BPD convert to OCPD as a means of overcompensating to more effectively cope with their trauma in a more socially acceptable way? Yeah, I do think that there are people who will develop strategies, and if that OCPD, that kind of that obsessive element of that, um, could be helpful. I think that there are ways to go after maybe the activation that might be a little bit more helpful than let's just push one way or the other. But definitely when someone has those emotional extremes, looking at anything that helps maybe expand that window of tolerance can be important. Do you have any recommendations working with a teenager who has a history of a traumatic brain injury and significant emotional regulation? For example, he can escalate from calm to highly reactive very quickly. What might a trauma-informed approach be adapted to this case? This is one that I think you have to feel it out. I would consider myself to be a pretty good ART therapist. I hope I'm good at it. But I had a patient who struggled during a medical procedure, has a TBI as a result, um, and cannot do ART, cannot do bilateral stimulation, especially anything visual. Um, and so I think as a therapist, you have to think through things in a way that can be helpful. Um, And yeah, I think you have to understand the brain injury, maybe understand how it manifests, and what sort of thing is going to help them regulate the most. If it's, if you have the EMDR tappers, if that's something, I have some patients who will sit with those on 24/7 throughout a session because it's a calming influence. Others, I'll jump over there and we're doing eye movements as a means of calming down. There are others that will do muscle relaxation or what's called a wet noodle, just kind of like sitting back and letting all the tension drip out of your body can be super helpful. So find what works, and then use that as something that would work through that. Can trauma occur when women engage in sexual activity where the husband experiences his orgasm and the activity stops? Well, I definitely feel like that a person could take from that something pretty significant about what do I mean in this situation? What's my role? Is this supposed to be something that's also pleasurable for me? Certainly, I think that there is something that can be worked through, whether that's with a couple therapist or if you're comfortable addressing that, helping maybe that person to understand the partner that sex might is a mutual activity and that there may need to be some things done that will be mutually rewarding and not just one way. But I definitely feel like someone could take from that something that could be very, very traumatic, and even start to experience some of those experiences. So when a partner starts to initiate, there is a trauma response to, no, I don't want to do that. How does it relate to OCD and intrusive thoughts? that activate trauma or pain. I have found that bottom-up approaches are incredibly helpful for OCD. Um, most of the OCD approaches are cognitive only. There was a time when something happened where those compulsive behaviors were first established as a means of coping. That is a perfect thing to process in a trauma approach, and it might help reduce some of those behaviors to where the cognitive approach of, hey, let's talk through that. What evidence do you have of this? Um, what would happen if you don't do the compulsion? Would the world end? No. Like that's where combining the two approaches might be super helpful. Whereas you might try a top-down approach with something like an OCD, but if there's a trauma base behind that, maybe address that first. I think of something like borderline personality disorder, and everyone thinks, oh, well, we've got to go over here. There's an established protocol for that. And I think it's great that we have therapy, techniques for that. I've got my cards. I can engage in my activities. I can regulate my emotions. That's great. That's awesome. But is there also perhaps a trauma piece to this? And if we treat the trauma, does that window of tolerance expand? Does my need to cope with DBT, does that go down? Um, why wouldn't I try getting at that, getting at this, coming at something two or three different ways? Yeah, it might make me more eclectic, but it probably makes me a better therapist for what my patient needs. And that's what I would think through. Would I use a bottom-up approach for younger children in a short 15-minute school setting? Yeah. There's a piece of training that is done called the safety protocol in ART as an example, where they train frontline emergency workers, ER nurses, to use bilateral stimulation as a means of calming someone. They train cops on the side of the road where they're working with a kid to help regulate the body. Certainly, a butterfly hug and bilateral stimulation. This is going to warm the body and kind of overwhelm that working part of the brain. It's going to help someone calm down, and we have strong evidence that that works. Whether it's the eye movements or tapping, both seem to work. We don't have a strong evidence for the auditory having as much of an impact. Do you ever do a 1 day training? So safety protocol, that's what I was talking about. Yeah, you can do a safety. I haven't done one. I just haven't scheduled it, but that is something I can find you someone who could do it for you if it's not me. So that would be something. Um, lifespan integration, I definitely feel like that is one that you can use. I'm not as familiar in terms of a trauma approach. I definitely feel like that is one from a top down, like you can start to do some of that. There are some somatic experiences in that, so I definitely see kind of that mixed approach. I don't have as much experience with it, but I definitely feel that when you're using something both top down and bottom up, that there can be benefits from that. How do you help people who are shut off in their body? First and foremost, we have to create safety and we have to create that calm that we can engage in. Can ART be done virtually? It depends on who you ask. Yes, I think it can be done. I do know therapists who do it. It's super helpful if you'll have your patient download an app like EMDR Tappers, and then they have like a phone and watch or two phones. They can have the bilateral stimulation done if they want to tap. If you want to use the ball from bilateralstimulation.io, you can do that. Um, I think the issue with doing trauma treatment remotely is thinking about the safety. Like if something is overwhelming for them, what's your protocol for that? So you definitely want to have a strong protocol, whether that's I can call in the mobile crisis team. I have access to resources. They know where to go. We have a plan in place. Um, so if you're doing trauma treatments virtually, I just want you to be prepared ahead of time. Worst case scenario may never happen, but at least you're prepared for it. I think we're at time, Kelly, so I'm going to spend some time maybe just answering a few of these after the fact. But I appreciate the time. I hope you learned something. I'm going to put the slides in the chat. I'll also put the handout together, so that if you want to use something like this or whatever, you're able to discuss that. So Kelly,
Absolutely.
it's all back to you.
Yes, thank you. Thank you, Nate. And I appreciate you being willing to, handle these questions. So if you've got questions still that you want answered, just stay on. Thank you all for being here. Please go to the chat, get that evaluation link, so that you can submit that the CE for your CEUs. And please know that, I mean, he's talking about putting the slides in the chat. We will also send those out with the certificate. So if you're submitting that evaluation, you will get those slides. If for any reason you don't need the CEUs, you're not submitting an eval, just send us an email, either me or Gabby, and we'll get those slides to you. But we really appreciate Nate's time and expertise and all of you for being here. And hopefully you can join us next month for another great training that we're planning. And thank you. So yeah, Nate, if you want to go ahead and answer more questions, we're good. We'll keep it going for those who want to stay.
All right, I just posted the slides in there and I gotta save my handout and I'll post that in there as well. All right. There we go. All right, that's in the chat. Let's go back to the question and answers. I'll just take a few minutes to do. Are you familiar with processing of positive memories technique, PPMT? Do you utilize this with clients to help benefit trauma? I am not familiar with PPMT, but I do think there is some value in doing that. I will say I find that there is the most value in activating someone to an extent, having them re-experience it in a safe environment, and being able to let some of the air out of that tire. But I can see the strengths-based desire there of going to positive things, and I definitely think there could be something about that. I'm curious about coherence therapy as a bottom-up approach, the emphasis on the process of memory reconsolidation for transformational change. I am big on memory reconsolidation. I don't know enough of coherence therapy to talk through that quite as much. Um, but yeah, that's one I think if you are using if you understand memory reconsolidation, when a memory is active and it's in the kind of that working part of your memory, it is technically editable. And what I mean by that is that you can work on reducing the sensations that go with that memory. When the memory is restored, you will have factual memory. You just won't have the automatic emotional response. That's the part that we've learned to cut out. And I would say the video that I referenced is called Memory Hackers. There's a piece of it that is um, it is a hack. Um, it is something that could be helpful in yeah, just getting to something that's in your brain that you might not be able to um, access normally, but it does offer us hope. I'm waiting for the time where we can start to combine that with additional things. I think that there is something um, powerful that you could do in working in that. I think that I'm kind of lost. I'm catching the chat as I go, but forgive me for that. I will figure out where I was and answer that. Um, I'm not as familiar with ART. Can animals be used with this type of therapy? I definitely think so. ART is it's a bilateral approach, and so we will use eye movements or EMDR, tappers. But generally, it's an eye movement therapy as a means of seeing kind of what you and then processing out sensations, seeing it and processing. In terms of a co-regulation, having an animal there could be super helpful in helping someone to remain calm. Does ART not rely heavily on the therapeutic relationship? Yes and no. I think one of the advantages of ART to some of the others, even with EMDR, an individual can process a lot of things without necessarily sharing all of the details with you. And so you don't necessarily have to, in fact, in some clinics, they have individual therapists and they have ART therapists, and they will send someone to ART, and someone can do an ART session without having a ton of issues or a ton of knowledge about that person because you really don't have to share too much. I've heard some people say, maybe I could do this with someone I know. Ethically, no, you can't. But if you're not telling me what we're doing, um, is that I'm not saying yes, you could do it. I'm saying it protects you as a therapist because they really don't have to share. In fact, the only question you ever ask, anything you care to share, the answer could be no. And I've had people where I'm maybe practicing just the protocol itself, and they're having a clinical experience, and I don't know that, which is kind of interesting. Do you offer any training sessions we can attend? I wish. I'm super busy teaching at UVU. Um, I do host trainings in ART. I'm not here to sell one approach over another. Um, I look forward to opportunities like this to discuss it. By no means am I the expert in trauma. I would tell you, um, go and learn as much as you can. Listen to the podcasts, hear from as many different people. You're going to get a ton of information from a variety of approaches, and you're going to make sense of that. If I do anything, we might be able to do something down the road, and I'd love to have you come if that is an issue that you want to address. So I think that's it for the questions. Thank you so much, and have a great day.
Thanks, Nate.
Thank you, Nate.
We'll be in touch, just with, and just again, you guys, I know people are putting in the chat. Yeah, send it to my email, send it to, we've got so much going on in the chat. Please send your request to either me or Gabby. If you are filling out an evaluation, you will automatically get the slides with your certificates. But if you're not filling out an eval, then just let us know. I put our email addresses in the chat. So, all right. Thank you. We will be in touch. This was amazing.